This next session is going to be around antibody-drug conjugates. There's been a lot of movement in antibody-drug conjugates, as you know. I think it's been the driver, along with immune checkpoint inhibition, but the driver of the transformation that we've seen in care. And at this ESMO, and almost every meeting we go to now, we see new data with new drugs, and then every now and then a big randomized phase 3 tears the world upside down. And we saw that very recently at our meeting at ESMO. I say our meeting, our European meeting. I'm joined here by some great colleagues. Shilpa, would you like to start by introducing yourself?
We have a mic. Oh, yeah.
That should work.
I'm Shilpa Gupta, medical oncologist at the Cleveland Clinic.
Mikhail?
Yeah, Michiel van der Heijden, medical oncologist at the Netherlands Cancer Institute in Amsterdam.
Matt Galsky, medical oncologist at Mount Sinai in New York.
Jun Go from Peking University, Kazakhstan.
We need data.
So, and Shilpa, is your mic working? Can you just say something again for me?
I can hear everything.
Hear me?
Yes, I think it's working, which is fabulous. Okay, so Jun, thanks for joining us.
Yep.
I thought it was a really good ESMO. I thought your data obviously was the most impressive metastatic data. It was a plenary session at ESMO. You got applause during the talk, which happens infrequently, and it suggests the data's pretty good. I'm just going to give the data, the top line data, if I may, and then I'm going to ask you a little bit about what your take on the trial was and a little bit about some of the details of the study. So the study is a classic randomized phase 3. It's a frontline, previously untreated patient population with advanced urothelial cancer. These individuals were HER2 positive. That's 1, 2, or 3 plus. And in your trial, that was the vast majority. It was about 80% of patients. It's also true in the patient population. You had slightly more patients with upper tract disease than we have in some of the other global studies.
Yeah.
The trial was relatively modestly sized for a big randomized phase 3, but because the results were so overwhelming, they were wildly statistically significant. Yeah. And you can see your hazard ratios for progression-free survival was 0.36. For OS, it came in the 0.4s as well. Your response rate was 76 versus 50%. And then you had a CR rate of 5% versus 1%. The adverse event profile is actually not that dissimilar to EV Pembro, and that's because this is a HER2 ADC as opposed to a Nectin-4 ADC, and they have the same payload. Now that payload is associated with peripheral neuropathy, and that was prominent in this study, as was fatigue. There was also some transaminitis, but one of the distinct features was Nectin-4 is expressed a lot on the skin, HER2 is not expressed a lot on the skin, and so you had less skin toxicity overall. And then there were 4 issues which we are going to discuss today, the first of which is how long you need to keep going for. We're going to have that difficult discussion. We're having that with EV Pembro at the moment. We're also going to talk about the HER2 biomarker. Does it really work? The third thing is the global impact on the trial. We're not giving toripalimab in Europe at the moment, and there is a randomized trial of Pembro DV, which isn't complete yet, but there's a question around whether or not people around the rest of the world will start to use DV toripalimab. You know, Turkey may choose to do it. Why not? Yeah. And I'm going to ask that why not question. And then the last bit is about, are we moving into DV toripalimab into muscle-invasive bladder cancer? Because Zinan Shen showed a path CRA of 61% associated with this combination, which didn't look too far off what we saw previously with EV Pembro in the last section, 57%. It's a small study, all the caveats with that, but it clearly is going to have similar results. Jun, tell me a bit about the origin of the trial. Tell me a bit about how you felt when you got the results. A bit about the standard of care in China. One thing about the trial I didn't say, no one got maintenance of avelumab in the trial, so that probably affects the PFS a little bit.
Yeah.
And so I would say the PFS is probably underestimated a little bit, but lots of people got subsequent DV or other ADCs in the trial, which probably diluted the OS signal. So compared to EV302, we'll have that comparison in a second. I think you said that before, you feel that the control arm performed pretty well. Talk to me a bit about what you think the impact of this trial is having on a global perspective.
Yeah. It's really a lot of questions. I think that's first, I want to say that we really enrolled half of the patients are UTUC. But the reason is that in Asia, especially in China, normally we have patients, half of them are UTUC. That's the difference with the Caucasian people. That maybe Caucasian is only 20%, but in Asia, like you can see the EV302 trials Asia Pacific data, they also enrolled half of the patients are UTUC. So that is normal. That is a has a natural things that we enroll the patients. Half of them are UTUC. The first question. Second question, you said that most people ask me about that. Why in this trial you have a very low the CR rate compared to EV302?
So the pass CR rate of 5% versus 30%, it does feel lower.
Yeah.
It's a lower number.
I think that different clinical trials could not compare the first. The second is when you see some of the reason I think that is in this trial, in our trial, you can see only 5% of patients get CR. But when you see the enrolled patients in this population, that less than 5% of the enrolled patients are stage 3 patients who only have lymph node metastasis. But in EVP trial, about 24 patients are stage 4, stage 3. And MEA even accounted for 40% of them. But in DVT trial, most of the patients enrolled is less than 5% are stage 3, and more patients are MEB and MEC. So maybe that could make some difference for CR. Because why I said that? Because you can see the chemo arm. The chemo arm also makes difference in the two clinical trials. Because in the EV trial, you can see the chemo control arm also have a higher CR rate than the DVT trial for the chemo arm. So maybe I think that that's one of the reasons. I don't know, but I think that because you have a DVP trial, DV combined with Pembo trials is ongoing now in America and Europe. I think that that trial will make sense to give the data. If in that trial, DV Pembo, if enrolled almost the same stage 3 patients in that trial, maybe the CR rate will get higher, maybe same as...
So Jun, we're going to explore that in a second. Shilpa, tell me what you first saw. When you saw Jun's data for the first time, what was your first impression? Did you think, I need to be HER2 testing all my patients and giving this therapy? Do you feel the follow-up is long enough? What were the strengths and the weaknesses of the randomized phase 3 DV toripalimab trial from your perspective?
Yeah, so congratulations on leading this trial. I was especially excited to see this come out of Europe and say, this trial was really, I thought the results were phenomenal. And I did have those questions to 5 weeks, saw so many similarities with the EV302, but then I was wondering if it is because they were more upper tract patients and they don't have a response in the primary tumor, if that was counted as measurable disease. Overall, it was very exciting, and I think the big question in my mind is how will this apply to the population in the US in terms of HER2 testing?
Yeah.
Let's come to that in a second. Mikhail, I'm going to ask you to take on the HER2 issue. So my impression of HER2 expression, and we did a study called LAM 20 years, was it 20, heaven forbid, where we looked at lapatinib, which was a HER1, HER2 TKI therapy, and it was flat negative. It was a TKI. It's obviously not an ADC, and there are lots of reasons. By the way, I was asked, some very bright person came to the stage after I'd given that presentation, and they said to me, ASCO, do you think, Tom, that if you attach chemotherapy to HER2, you could actually make this a positive trial? This was 50 years ago. And I said, no, that's a ridiculous idea. So there is a story there, but 80% or 75% of patients are HER2 positive. It's quite a lot of patients. We've looked at the zero population, the HER2 zero population, and in small numbers of patients, the response rate may be lower. Do you really think we've explored this HER2 biomarker adequately? You can see that there's no enrichment in outcomes associated with the HER2 3+ compared to the 1 or 2+. The data from TDXD, which is approved in the 3+, is sketchy at best of 16 patients. There's no concordance in HER2 assessment when you compare the central review with the investigator review in that basket study for TDXD. Is this a case of the emperor's new clothes, where we think because it targets HER2, we should use it, but we haven't really tested properly that the zero population don't benefit, and you would expect the HER3 to do better? Where are we with HER2 biomarkers in this disease?
Yeah, so that's an excellent question. So the first thing I saw was this, this is a great result again, and is completely similar to EVP. I think, the whole thing about CRs, I think that's just noise. I want to add that, that if we're judging whether something is clinical, investigator assess the CR or not, and, you look at the bladder wall, is this a CR? There's still a little bit of thickening. Is it not a CR?
5% compared to 30% is noise?
I think it has to do with the central assessment, that they were just done quite differently and stricter in a way. I don't think that's a real difference. But to get back to the HER2 thing, it's not what I had expected, because the earliest data seemed to say that there was actually a difference between the high expressors and the lower expressors. But in the end, this as well is also very much in line with EV, where we don't really see a difference in expression. And sometimes we feel like, with this whole vedotin ADCs, have we just discovered a very, very fancy chemotherapy for bladder cancer, and are we packing it either in a Gucci bag or a Dolce & Gabbana bag? But it's still the same type of treatment.
But your feel that we've not seen these sorts of results. Why? And Matt, I'm going to ask you the same question. Why didn't we see the same results with chemotherapy? So we put immune therapy. If you just think it's chemotherapy, Keynote 361, well-designed, prospective 1,000-patient study, no benefit associated with the combination, statistically insignificant.
No, we still need to target it to the cancer cells,
but if it was just chemotherapy, if it's just fancy chemotherapy, then how come chemotherapy and immune therapy fail so badly? And how come we're getting these amazing results of 0.3s and 0.4s? It doesn't feel like chemotherapy to me.
No, you still need to target it to the cancer cells, so it still needs to be
So it's not just fancy chemotherapy, there's something different or not? I don't mind if you say it's just chemotherapy. It's up to you, I don't mind.
I think vedotin, if you would give it solely, it would be too toxic, so you need to still package it. But how, I think we might in the future, if we keep developing this, we get other antibodies that work as well. So the vedotin ADC.
My last question, if I can say, is around the zero population. Have we explored the biomarker properly in the HER2 zeros? So we've done the randomized phase 3 in Europe. We've also agreed, or the rest of the world, we now agree that the zero population, we've left them behind. They did the same with tamoxifen in breast cancer. Because it targeted ER, they went in the ER positive patients. They never tested the ER negatives. We've essentially done the same here. Have we made the same mistake the breast cancer doctors made 40 years ago? Have we learned nothing?
So a small study in China, 0 responses. Very small study, but how many patients do you expose to the treatment before you decide? I mean, I think it's a valid question. I don't think we've answered it adequately, but at the same time, it's not that there's no data. There's data showing that in a very small subset, 0 responses.
Yeah, I agree with Matt. Actually, in China, we have a small study just for 0 and 1+ patients using DVT treatment. And we found that for the 0 population, the response rate can only get to 20 to 30. But if the patients have 1+, the response rate increased a lot, more than 50 to 60, 1+. But the 3+ population, the response rate can get to 80%. So I think that 1+ maybe something like bystander effect make the 1+ patients also have very good response.
Okay, so there is some agreement that we feel we're going in the right direction, but no one here feels we've really nailed this HER2 biomarker. Is that fair? Okay, Jun, question for you. What global impact will have your trial have? We know in the United States of America and perhaps in Europe, the EMA, although the EMA has set a precedent where they have accepted exclusively Chinese data previously. I don't know what the FDA will say. What impact will this have outside of Europe and the United States? What's going to happen in South America, Asia Pacific, Vietnam?
Yeah. It's really difficult to answer that because I'm not the United States doctors. So depend on the doctors and the patient's choice. I think that it's a good thing for all of us is that in the first line metastasis UC, we have 2 choices now. I hope that many choices we have. But in America, if they can, the FDA could after they read the data, if they can get approved the new DV in America, I think that after the DVP trials finished, I think that maybe they can get approved. But in China now we have 2 choices, and I love EVP, and I also love the DVT for patient selection, and I think that we a lot of things we need to consideration when we make decision for the patients. Which strategy is could more benefit these patients, and after that we should think about a lot of things, the price of the drug, the side effect, and after failed with this first treatment, what kind of second line, third line left for us?
So let's keep going. Here we've got a slide in front of us, and just to summarize it very quickly, it compares EV Pembro with DV toripalimab. Platinum chemotherapy is the control arm in both. In the EV study, 30% of the control arm got maintenance of avelumab, probably with a tailwind. We saw from the DISCUS study about 50% of patients can get avelumab. Overall, it's not 100% of patients get avelumab. We know that, but there may be a small advantage there. We chatted about that. We see the DV toripalimab patients, a lot of them getting subsequent therapy, particularly with the ADC subsequent therapy, which I think rescues a lot of those patients. When you look at the overall survival, you can see the survival of the 2 arms very similar to each other from the control arm. Actually, the follow-up of the DV toripalimab is a bit shorter, was much shorter than the most recent data with EV pembrolizumab. The CR rate we've talked about. At the bottom there's a Uromigo score. We've started making this scoring system. We asked 32 people around the world last week how they would score these two regimes out of 3. And they were from all around the world, and 3 being the undisputed standard of care, and then 2 being a good treatment, 1 being a less good treatment, and 0 being a treatment you should really avoid. Matt, here at the Uromigo score, we got 3 out of 3 for EV Pembro and 2.5 for DV toripalimab. How would you explain? I mean, they're both great scores, by the way. They're both above 2, which is sort of the standard. Why do you think one might have a slightly lower score than the other?
I don't know. I gave both a 3 out of 3.
Very political answer. Well done. Sitting next to Jungo, I would expect nothing else. Anyone prepared to put their hands up and said there's 2? Shilpa, did you were a 2 or a 3?
No, I did give it 3, but I think it could be because people might be wondering what would the data be in the US, you know.
So it's about what does this apply to a global perspective to that question. And Matt, is that your agreement too, or do you think that CR rate is, I mean, Mikhail's already said he's put the CR to one side. The duration of response, 23 months versus 16 months. Again, those numbers are not identical to each other. It's an exploratory analysis, but a CR rate of 30% with duration of 23 months, a CR rate, or response rate. Are you confident that these transformative responses with a longer follow-up we've seen with EV Pembro is also the case with DV toripalimab? Are you confident in that?
So 20 patients, have to take it with a grain of salt, but phase 1b study, DV Pembro, 20 patients, CR rate of 30%, right? You're involved in that. And so I think it just shows you that context matters, where the study's done, who the patients are, how it's read out. I'm pretty confident that the results are similar and hold up.
Do you agree with Mikhail then, that you think this 1%, 5% is probably underestimation, and actually that in the randomized phase 3 global trial, which Jungo talked about, it's going to bounce back up to 30?
Yeah, but I think it's not. I think it's all the reasons that were stated. I think it's the upper tract disease and not having those tumors. Those tumors count more than patients with thickening of the bladder with primary bladder tumors intact, just how they're assessed. It's based on the central and investigator review and the nuances around that, and then it's based on the patient populations as well.
Shilpa, if you don't have to test for HER2 status and the two regimes look similar and the data with EV Pembro is longer in a global trial, why would you bother doing HER2 testing, and why would you bother with DV toripalimab if you have both options available to you? Why would you spend that 2 or 3 weeks getting the test? Would you not just give everyone EV Pembro?
I would.
Oh, okay.
But if I were not practicing in the US, then I would certainly do DV Tori because of the financial implications of EV Pembro in the rest of the world.
So, we do have an approval in the US based on HER2 testing in bladder cancer, and so many of us get that testing routinely, and some pathology labs actually do it automatically now on cystectomy specimens. So we're not necessarily waiting 2 to 3 weeks in many of our centers.
And this is the first global ADC personalized therapy trial that's positive. There's some breast cancer studies looking at PD-L1 populations that do combinations. But this is the first targeted study. There's a lung study targeting TROP2 using an algorithm, which I think is exciting. But this was the first personalized study, which I think is fabulous. I'm going to move on, if I may. And this is one of my colorful slides that Brian hates. He hates all my colorful slides. It's just one of the T-shirt. He doesn't like my. We had to form a separate T-shirt committee for the Uromigos T-shirts because he didn't like the T-shirts. Did like the T-shirts, but he felt it was distracting. But we had a T-shirt subgroup for organising this meeting, which was actually a great fun group. But here, that group also came up with the colours in this slide. And to summarise a very long story, we have a series of data currently coming out of largely China with newer agents. We're comfortable with two drugs. We're comfortable with DV plus toripalimab. China is comfortable with DV alone. We're comfortable with EV Pembro being transformative. The sacituzumab govitecan data has not been overwhelming. It was a negative randomized phase 3 as a single-arm trial. In that trial, I think we learnt a couple of things. Number one, I think there was a toxicity signal, but we also learnt that there may be an issue with the topoisomerase payload. and there may be an issue with the TROP2 target, and I want to talk to you all about that in a second, so that's going to be our next topic. But just before we let this slide go down, I think it's also fair to say we've more recently seen other TROP2 topo-1s with maybe more activity. SAC-TMT looks like an active drug, and then we've even got a randomized trial with DDXD. And now, just before we move on, I want to talk about a Me Too trial, and that is the study with the Bicycle ADC, the Nectin-4 MMAE peptide, not ADC. And so we can complete that slide, we can move on. Is any of the three of you taking part in that study with the Bicycle drug, Nectin-4 MMAE? It's a randomized phase 3. It had a phase 2 component to it, and it's run into a phase 3. Is it still possible to do these trials if they're not completing anytime soon? And is it ethical to recruit patients to these studies if you haven't got availability of the drugs? Yes, of course it is. But if you have got availability, are these studies ethical? Mikhail.
So I think if you, we don't have EVP yet available, and we participate in the DV trial, not in the Bicycle trial. And in that situation, patients get chemotherapy, so I think it's ethical. In a situation where EVP is available, I don't think it's ethical to randomize patients to chemotherapy.
And how will we interpret these ongoing trials because even the UK now has EVP, dare I say it, and it's going to be very hard to if those trials aren't going to finish in the next year, it would be impossible to start a new study with platinum chemotherapy. When do we come to a point when we say we just need to stop doing these studies? I mean, if that trial wasn't 3/4 of the way through, what advice would you be giving them?
So I think, given the results that we have, and with the hypothesis that whatever you target vedotin in bladder cancer in whatever ADC you targeted to the cancer cells would work, I think you would need to have at least the same type of hazard ratio, same type of results. So I think you have to really look closely to your sample size calculation and see if you can close the trial and report. And probably, given that there's now probably already 2 alternatives with either EV or DV as a first line option, you probably have to use that result and start looking for another setting where you can maybe test your combination or your drug again. So it's still an important result to know if these drugs work as well as the others, but it's probably going to be very difficult to beat the current 2 established already combinations.
Shilpa, before we move on to the next slide, I've gone forward too, I apologize. Before we move on, I wanted to ask you a question. By the way, we're going to talk about sacituzumab govitecan next, but before we get there, can we sequence EV and DV? So, Jun, you have access to both.
Yeah.
EV pembro, DV toripalimab. If the cancer grows after EV pembro, will DV toripalimab work, Shilpa?
I think that's a very important question. It all depends on the toxicities the patient is having. If they have bad neuropathy, then you want to avoid the vedotin again.
That's one. But Matt, what's your take on sequencing these drugs? And because the data that I read talks about the payload being the driver of resistance, not necessarily the target. And so you might be better off switching payload than switching target. Here we switch target from Nectin-4 to HER2 with EV and DV, but the payload is the same. Is that going to be a problem for us, or do we just not know yet?
I don't think we know yet. I mean, I think a lot of the translational work that you're citing is based on very limited numbers of patients getting biopsies on treatment. Anecdotally, yes, I have seen patients respond who have gotten DV and then EV. It's not everyone, and so this is not going to work for all patients, but I don't think there are absolutes here. Some patients progress because of resistance through one mechanism and other patients through a different mechanism.
So let's talk about the standard of care after DV toripalimab or EV pembro. Is it platinum chemotherapy? Jungo, what are you up to?
Yeah, actually, we have a few experience using the sequencing of the ADCs. Because in China, we only have 2 ADCs get approved for blood cancer. So after EV failed, sometimes we only have EV. So we try DV alone, and we do find some patients still have a response. And similarly, the patient who failed with EVP, DVT, we try EV alone, also have some response for patients. So I think that now we have a very important thing is that we need a clinical trial. And first, I think that after EVP or DVT, should we use the PD-1 combined with ADC again or alone with ADC? Just like the renal cancer.
So my take on this at the moment, and I'm happy for you to disagree with me, and please do shout out, but the standard of care is either DV toripalimab or EV pembrolizumab as first-line therapy, and after that, platinum chemotherapy is the standard treatment.
I agree.
I mean, it's the standard based on nothing. We have no data to show that it improves outcomes at all in that context. We need a,
Give me an alternative.
we need a placeholder there for doing clinical trials, and it's as reasonable as anything else. But I think to call it a standard is to raise it to a level where we don't have the evidence.
Jonathan Rosenberg, who's here, will probably talk about his retrospective series from Memorial. It's retrospective, it's tertiary referral, all the caveats with that. The data response rate, the data looked okay, but that's where we are right now. So we're agreed that still, no one's saying we should give EV Pembro and then DV toripalimab. Is that correct? Like if you had unlimited budget in a private healthcare system in the US, you wouldn't be sequencing those two? No. Okay, that's really helpful. Okay, I want to talk now, if I can, about what went wrong with topoisomerase payload. Jun, some of the data I showed us before that when you use Nectin-4 ADCs with topoisomerase payloads out of China, your response rate is much higher than when you use TROP2 with topoisomerase payloads. What's going on in China with the topoisomerase payload early phase trials, and are they promising?
Actually, in China now, we have a lot of ADC clinical trials in blood cancer, like we called A21002 ADC. That ADC is the target is Nectin-4, but the payload is a CHOP1 inhibitor. So when we use that ADC treated patients who failed with DVT, and we found the response rate is very good. The monotherapy using that ADC, we didn't use that ADC combined with PD-1 again. So I think that maybe in the future, different target and different payload, maybe sequence is good.
So Matt, what we're hearing is that it may not be the Topo1 payload. What's your take on TROP2 ADCs in urothelial cancer right now?
I think that this is evolving, right? So we saw data with Dato-DXd plus, and I forgot the name of the antibody, forgive me, but it's the PD-1 or PD-L1 TIGIT, but bispecific, with response rates that are approaching what's seen with EV Pembro at ESMO, right? And so I think we're making a lot of assumptions based on small data sets, but the story is yet to be fully written. I think TROP2-based ADCs and topoisomerase payloads, we still need larger data sets to fully understand where those are going to fit.
Mikhail, why did TROPiCS-4 fail? And was it an event which has disproportionately turned us off this group of drugs? Or when we have a big negative randomized trial, should we listen to it and not further evaluate these drugs? And do you believe these three drugs, Dato-DXd, sac-TMT, and sacituzumab govitecan, different linker molecules, different toxicity profiles, do you think the same or different?
So I think all these ADCs with the same, combination, basically, they all have activity, right? So they do, we do see responses in a number of patients. I think with the sacituzumab govitecan trial, there were a number of problems with the large phase 3 trials, which, is always easy, of course, in retrospect, but with the dosing probably and with how to manage the patients, there were some problems. I think it's also in the time when EV was starting to come into play, so maybe that has played a role as well in subsequent therapy. And, all these things, may have led to it was not a far miss, right? It was quite close still to
There was
being
quite a lot of early neutropenia
But it was-
sepsis death.
Right. So I
14
think a lot of things with the
patients.
dosing and with the management of patients, specifically in bladder cancer, was not right. In retrospect, right? So it's always easy. So I think in that situation, it's still possible, I think, to have with these types of drug a positive trial. Is this a major improvement for metastatic bladder cancer patients? I don't think so. At that point, you basically have already missed out on the jackpot, which is in, I think, metastatic urothelial cancer, that we're providing long-term durability, maybe cure in a subset of patients. So it's a small difference that you can make, but I think it's still possible. And based on these data, and that remains very difficult, that we see all this data from 30, 40 patients. You're talking about 12 versus 16 responses in such a data set, and then we're going to make a big deal out of it. I think it's really too early to say if any of these are much better than the others.
There was some very impressive sac-TMT data in lung cancer at ESMO that just went by. There was a presidential session there. I sat through these presidential. I thought they were fabulous. But I looked at that and thought, oh my goodness, that looked really active to me. Shilpa, you're a practicing US doctor who has a huge experience in this field. The NCCN hasn't taken sacituzumab govitecan off its recommendations, I'm told. Are you using the drug which has a significant toxicity signal and a negative OS signal? Are you still using it for patients?
No, I'm not. And so for toxicity, first of all, I always used prophylactic growth factors even when it was available, despite the company telling us we don't need to, which I think was a short-sightedness in the phase 3 that they did not
They
mandate.
did change their mind. We did change the
Right.
protocol towards the end.
Yeah.
So
But in my practice, I'm not using it because it did not show efficacy. So it's not better than using taxanes, in my opinion. So why would I use it?
Matt, were you giving it to patients?
Once in a while I will. I think that we have limited numbers of drugs still, despite everything that's happened in the field. And so drugs with single agent activity, we still need to consider in our armamentarium when appropriate.
In front of us here, we have the global randomized phase 3 ADC studies. And there are some ongoing perioperative trials. There's the EV Pembro trial. We discussed that in the previous section. We're not going to go through it again now. There's also the Volga study, which is EV with Disitamab vedotin plus or with or without CTLA-4 tremelimumab. Again, I'm not going to talk about that now because it's a perioperative study. But we've also discussed the DV Pembro trial and the versus platinum chemotherapy and the ZP, the trial, the Nectin-4 MMAE peptide with pembrolizumab. That's also against platinum chemotherapy. We talked about both of those studies needing to finish relatively soon before EV Pembro becomes the standard of care globally. It can still recruit in some parts of the world, but not everywhere. And I think the FDA insists on a certain footprint coming from the US. And I think these trials clearly are going to struggle in the US. But then in the IO-experienced metastatic space, I think things are slightly more interesting, where instead of seeing what I would describe as kind of Me Too studies, we're seeing these new drugs. The HER1, HER3 Topo 1 ADC, Isobren, versus platinum chemotherapy. So we said platinum chemotherapy was the standard of care, and now we've got a single agent ADC going against that. It's got a single agent activity, 41% response rate, again out of China. That trial's open and it's recruited its first patients. It's a global study. I think it will recruit fast. I think it's an important study. Again, we saw some nice isobren data in a different tumor type in nasopharyngeal head cancer, showing positive PFS. The second trial, I think, is controversial because we're now seeing Dato-DXd. The response rate was a bit modest, about 25%, I think, out of the MD Anderson, and here we're combining with platinum chemotherapy. I don't know how you folks feel about that. Should we be combining? Does that feel like a step forward or a step backwards? Again, it's against platinum chemotherapy. And then the third trial, I think, Petros, you're involved in this study, sacituzumab govitecan plus or minus pembrolizumab, the re-challenge with immune therapy. We haven't tested that yet. I think it's an important question, and that's against taxane chemotherapy. I would really like us to focus on the green box, not the Me2 sec first line box or the previous neoadjuvant box. Matt, I'm going to ask for you to start with which of those three studies is your favorite and why?
I'm going to make a political answer here.
Your conflict of interest. I asked you on purpose so you could say this. It won't be the Dato-DXd study, but it's...
I think the nice thing about these studies, in all seriousness, is that they're each asking a complementary question, right? So ADC plus platinum, we need to answer that. Immune checkpoint blockade re-challenge, we need to answer it. And I think the single agent novel ADC versus platinum, we need to answer that. So they all offer something. They all have a similar control arm. You could see network meta-analyses being done when these are done to try and decide what to do per patient.
Mikhail, which one do you like? Which one are you opening the NKI? Which one are you going to get behind?
So I think that the isobren is an interesting concept. It's it's an even more modern type of ADC, which is in a way as an investigator attractive. So I think that's a neat trial. I mean, they're all important trials. And I think for the trial in the middle, the Dato-DXd, I think it is an important question, but it would have really helped if we had a third arm with only Dato-DXd. That would really have answered the question of the contribution of those components, because after monotherapy, you could still receive platinum-based chemotherapy.
But Mikhail, if Dato-DXd as a monotherapy had a lower, I know the small studies, indirect comparisons, all the caveats, but it doesn't look clearly better than SG, Dato-DXd, and SG didn't beat taxane, DXd, I assume platinum chemotherapy is going to be more active than taxane therapy, single agent. If you can't beat taxanes, can you beat platinum chemotherapy?
If you can't beat them, join them. Isn't that what this?
If you can't beat them, I love it. I love it. So I think that's right. Shilpa, which of those three do you love, and which trial would you like to see that's not there?
The trial that I would be behind is the isobren, because that's a solid control arm. The Dato-DXd plus carbo, to me, literally we're comparing gemcitabine versus Dato-DXd. So, that doesn't make too much, like Dato-DXd mono versus platinum would have been a better, arm to see what Dato-DXd is adding, because we can't really tell whether carbo is doing the job or Dato-DXd. And lastly, I think the SASI plus pembro versus taxane, it would be good to have another arm of pembro mono in that, or some IO, because it will answer the question of what SASI is doing. And so I think it's a very heterogeneous population.
It's the Dato-DXd, it's Dato-DXd platinum versus platinum chemo. It's not just carbo.
So
Triplet, carbo gem plus.
No, it's Dato-carbo or Dato-cis, depending on what a patient's eligible for.
So the last question on this issue from my perspective before we move to the next slide, are any of you re-challenging routinely with immune checkpoint inhibition in urothelial cancer?
No.
Jun, this is over to you a little bit. So I went around the rest of the world, and then I went to China, and we looked at the Chinese trials that are ongoing.
Which one I like?
Because
I think that I like the Dato combined with chemo. Yeah.
You like the Dato chemo?
Yeah.
Jun, I didn't ask you because I wanted to ask you specifically about the 4 Chinese randomized trials that are ongoing. So the rest of the world is doing maybe these trials challenging post-EV pembro. But here in China, you've got a series of new drugs that you're looking at. some of them very novel, we haven't heard of before. Trastuzumab vedotin, which is the HER2 MMAE versus taxane chemotherapy.
Yeah.
That feels a bit like DV, but it's a new drug, it's not the same. Then you've got that Nectin-4 Topo1 versus taxane chemotherapy. You said that's a very exciting study. Ding Wei in the audience, I think, leads that randomized phase 3 study. You've also got an Isobren trial, but this is going first line, not second line. And then finally, you've got what looks like EV Pembro, but it's a EV-like drug, Nectin-4 MMAE toripalimab, versus platinum chemotherapy. June, which of those 4 trials do you feel you're most excited about, and why?
Yeah, actually, for me, is the Nectin-4 top one trial excited me more because actually, in my opinion, now we have 2 great choice for first line, like EVT and DVT. But the most challenge for us is the second line, because the standard treatment of second line now is still chemo. So we need a great group progress get for the second line. So that trial, why this trial excited me more is that because most of the patients in China now is filled with first line with DVT. So the Nectin-4 top 2, we have shown the response rate is very good and the side effect is modified. It's good. So this trial maybe give us some new message that we could build a new standard for the second line treatment better than chemo. That's the reason. Yeah.
Mikhail, when you look at those slides, do you think China's going faster than the rest of the world? Are they asking better questions?
Well, I see 2 trials in the first line still randomizing against chemotherapy, so I wonder after your DV toripalimab results if that's still ethical to do. And for the IO experience, I think it's basically trying to answer the same questions that we're doing in the trials you just showed us. So I think they're all important trials, but yeah, it's basically the same questions.
Matt, which one do you like most of the Chinese studies? And do you wish you were a young budding doctor in China right now or a young budding doctor in the rest of the world? What is the answer to that question?
No, I agree with your take. I mean, I think that, these are the studies, these are the drugs that we might be studying in the US in 2 and 3 years from now. And so I think you're right that we need to pay attention to what's going on. This is a major shift in drug development.
Just before we finish, I wanted to ask a quick question around EV or DV rechallenge. So if we're giving 9 cycles of perioperative EV Pembro and a patient then relapses a year later, are we rechallenging with EV Pembro or DV Pembro? Number 1. And number 2 is for those patients with heavily metastatic disease who have been round the block, let's say they get EV Pembro, platinum chemotherapy, TDXD, and then a year later, are you coming back to EV a second time? So are we haven't generated any data. How is this an important research question, or are there better things that we should be doing with time? I can tell you my personal experiences, I've rechallenged on a number of occasions, and I've seen pretty good results. What's your rechallenge experience like, Shilpa?
Yeah, I do rechallenge also, particularly if I've stopped after a patient has had a great response and developing toxicities with EV. And because they had a response initially, I would rechallenge later. So like an intermittent approach, I think that's a very valid question. And to your point about if we use EV Pembro in the perioperative setting and then the patient recurs later, I think, I don't know about IO after IO, but I would be very keen to use DV, especially depending on what the path-CR was. If patient did not have any pathologic response with EV, then I would certainly use DV. But if they had a path-CR and they still recur, then I would re-challenge with EV.
Mikhail, would you ever re-challenge with EV Pembro? Let's say you had perioperative EV Pembro. Would you ever re-challenge with EV Pembro?
So I think if you've given EVP in the perioperative space, you had a year of follow-up. I think, I did a session at ESMO where if you look at this trial so far, but it's new data with EVP, but the number of most patients who progress in the either on adjuvant therapy or shortly thereafter, so at least in the first 2 years. So we're spending a lot of time talking about a very small number of patients who recur very late, more than a year of observation later. I think, sure, it's fair to then, try the established great, first line EVP.
Matt, you've talked about your EV, DV. You've used a lot of DV and EV in your institution. We have two. And the number of patients getting the opportunity to cross over to the other drug, at the moment we don't know much about. Where are you in your practice with this whole piece? Once you've had this group of drugs, do you just move on?
Yeah, I mean, without DB being approved in the United States, it's more of a theoretical issue in these patients who've been on study. And for the patients who've been on study with DV, of course, with the track record of EV, you like to give them the chance to be exposed to EV. So it's a little bit more straightforward. If both of the drugs are out there and approved, then I think these are still patients with metastatic urothelial cancer despite the improvement in outcomes, and many of our patients do not get third and fourth line treatment, let alone fifth and sixth line treatment. So I think we have to pick our lines of treatment quite carefully.
Yeah, and use your best treatments first is one of the rules. Jun, you've had a lot of experience of DV now.
To be honest, we never used to re-challenge DV or EV again for the patient because we have a lot of clinical trials. The patient maybe can, after failed with this compound, they can enroll in some other clinical trials, or even I think that to re-challenge, we didn't do that. Yeah, maybe.
I'm going to wrap this up now. I'm going to start with Shilpa. I wanted you to predict the future for me. So I want you to tell me, with all of the activity and those randomized trials that we saw that are coming out, the studies that we know about, the information that we have in the public domain, where do you see advanced urothelial cancer and ADC development landing over the next 5 years? Assuming all of those trials read out, what are we going to do? Where are we going to be?
I think it would be, when we're seeing the ADC IO move earlier in the settings, and I think it would be really important to have a lot of non-cross-resistant ADCs so we can just switch the ADC partner from the backbone. Let's say somebody progressed on EV Pembro, drop the EV, use another ADC, and I think that switch ADC approach would be something we should be looking for.
So ADC switch. Mikhail, do you agree with that? Have you got another theory about where it's going to land? If there is a switch, what's that switch going to look like?
So, I think what's so great about the time in bladder cancer we're now in is that we're actually, particularly in a metastatic setting, but now also in improving cure in the non-metastatic setting. But in the metastatic setting, I think we're always very careful, but providing durable remissions or maybe cure in at least a third of our patients, which is really fantastic, something we've been always dreaming about. And we're now focusing a lot on getting a lot of new ADCs with a response rate of 30 or 40%. Whereas, I hope that and I don't have the answer for you now, but I would hope that we still can find a way of still further improving that cure. And I'm not sure if it's really been throwing in more ADCs. Again, I don't have the answer for you right now, but
Matt, I want you to talk about
focus. And now in the trials we're doing now, we don't really have the patients. We only look at response rate, short response. Most of the trial follow-up is like 1.5 years on these single-arm trials, and then we forget about it. And we should also be looking at the long term because I think that's what patients really want.
There's a Forager trial with EV Pembro plus an FGFR inhibitor versus FGFR alone. Versus EV Pembro. So EV Pembro versus plus or minus FGFR inhibitor. That sounds progressive. Matt, do we have other combinations that we should be exploring, particularly the ADC combinations to cure bladder cancer? There's the DAD study, there's a DADIO trial of SG plus EV. Is that the best way to go forward? Instead of Shilpa sequencing, should we be piling it all in up front to try and cure more patients?
I think, to Mikhail's point, we need to test that concept, notwithstanding the toxicities that are involved in those regimens, in the financial toxicity as well as the real toxicity. We have to be mindful of that, but I think at the same time we have to test that concept. There's that anecdote that the components to cure childhood ALL, the individual components existed like 15 years before the regimens were put together. And so, yeah, I think that's sort of the North Star in oncology, right? We just need the drugs with single agent activity that's high enough and non-cross-resistant enough with other drugs to eradicate cancers. And if we can do that, then we should not be giving the drugs sequentially. We should give them all at once and knock out the cancer.
Jun, the last word from you. Okay. What's the next big thing going to happen out of China in urothelial cancer?
Yeah, I think that I just mentioned about that. We should to do some clinical trial to find the better way for the second line. Second line is the most important things for patients, because we have two very great regimens for the first line, but second line actually we only have chemo now. Maybe ADC combined with ADC combined with chemo, ADC combined with some new ICI, I don't know. So we need to try to find a better way for the patients with the second line.
I quite like the ideas of ADCs plus the new VEGF PD-1 bispecifics. I think for me, that would be a next big step. I'd like to see those trials take place. They're happening in other cancers. They're happening in lung cancer. We should be bringing these drugs into urothelial cancer. That, for me, would be a good step. We're going to draw a line under this. I'd like to thank Jun, Matt, Shilpa, of course, and Mikhail. Great session. Thank you very much indeed. We're going straight into this ODAC, aren't we, bro?